Welcome back to another episode of the Braun Performance and Rehab Podcast. Joining me today is Josh Davis. Josh is a physical therapist based out on the West Coast, and Josh and I are going to be diving into bony stress injuries, so stress reactions, stress fractures, and so on that way. And we cover a lot of different topics around that today, relating from DEXA scans to examination considerations, rehab considerations, case studies, and so much more. So we really cover a lot of ground in this episode, and I know you're going to really enjoy this and learn a lot from it. This episode and every episode in season 5 is sponsored by Isophit. Isophit is my go-to for all things isometric strength training and can help you and your athletes win more and hurt less. For more on Isophit, you can check the description below. Enjoy.
Josh, welcome to the podcast. I'm super excited to work with you today, man. Thank you so much for being here.
Yeah, thank you so much for having me, Daniel.
For people who might not be familiar with you and all the amazing things that you're doing out there on the West Coast, would you mind filling them in a little bit about who you are and your practice that way?
Yeah, I am a physical therapist and strength coach. I work for a small private practice where we see a lot of active adults, youth athletes, quite a mixture of things. I also own my own company, Beyond the Barbell Rehab and Coaching, where I do a little bit more of a hybrid integrated model, seeing people in person, creating programming for them that kind of fits their needs and trying to get them back to what they want to do. I graduated from 2019 from PT school. I did a orthopedic residency at Cincinnati Children's Hospital. A lot of great mentors over there, especially in the youth athlete world, ACL repair. So a lot of fun experiences. And after finishing up in Ohio, I've now been out in Oregon for almost 5 years now, 4.5 years. I mean, it's crazy how fast time starts to fly by.
No, you can say that again. It is absolutely insane. I just think about where I was, even when we started the podcast 5 years ago, and it's like, it's been 5 years already. Really? It doesn't feel like it's been that long. Time definitely goes quick, and it's one of those things where certain injuries also need that timeline component to heal. And I don't know about you, but especially in the athletic population I treat, I've been seeing a huge increase in bony stress type injuries, whether it's stress reactions, stress fractures, and so on that way. And these are something that a lot of kids have been told, oh, well, you just need to rest it 4 weeks and then you can, go back to doing what you want to do, or just rest it 6 weeks and then you'll be good. And that timeline component, in the moment goes by slow for them, but then they start to go back to sport once they're quote unquote cleared, and time slows even more for them because they're not at the level that they want to be at after taking 6 weeks off and doing nothing, which, is a shocker, obviously. So I think it's one of those things where it's a very common diagnosis we're seeing, bony stress reaction, bony stress fracture, something like that. But a lot of times I think clinicians are misunderstanding it and not necessarily approaching these from the best point of view a lot of times. And, maybe I myself have made mistakes in how I've managed them in the past. So I think it's essential for us to dive into that, just starting from that 30,000 foot overview, for lack of a better way to put it. When you hear bony stress injury and you think about something stress reaction or stress fracture in a bone, what are you typically defining that as, and where do you typically see these occurring or forming in the body that way?
Yeah, that's a great question. And, to touch on your first point, I have definitely seen a lot of these this year, especially in that younger youth female athlete population. And how they come in as a diagnosis from me, from a physician, varies everywhere from I have a stress fracture to kind of like you said, like I have stress reactions, I have shin splints, and then trying to put it all together and like from a clinician standpoint, okay, exactly what does this mean? What did the physician tell them? And now what am I giving them in concert to create that holistic plan? But, if we had to break it down, a stress fracture as it is essentially just a small crack in the bone that is not as big as a regular fracture. And from a bony injury standpoint, bony stress standpoint, it is some type of inflammation within that bony area that has occurred from usually a repetitive force such as overuse, usually often in jumping athletes, running athletes. And I think, one of the biggest pieces that sometimes maybe gets missed is that with these things, there's often poor nutrition and poor recovery. So kind of to talk just a little bit about that timeline that you talked about, that 4 to 6 weeks, that's one component that if we're not addressing, and maybe we'll talk about a little bit more, they're probably going to find themselves back in the same place. But common areas to be seen are the tibia, fibula, metatarsals. You can have them in the navicular. They're less common in the upper extremity region of things, but I think the most common area, especially with some of our distance running athletes, is the tibia and fibula.
Yeah, no, I think that's a great breakdown, and you brought up so many amazing points. And I've definitely seen majority tibia stress reaction, stress fracture type stuff. And then I would say I also see a fair amount of femur and pelvic stress fractures as well. But you're right. I think they generally tend to be lower extremity in nature. You brought up that point on repetitive force and overuse and, poor lack of recovery and that sort of thing. And I think that definitely aligns with what I've seen clinically as well, is a lot of times it's athletes who, their season, quote unquote, never ends, right? It doesn't matter what the sport is. I don't care if you're a runner, if you're playing lacrosse, if you're playing soccer, whatever it is. The concept of an off season looks a lot different nowadays because of travel sports and sports specialization and that sort of thing. So a lot of the times I'm seeing athletes play their school ball season and then literally the next week start right up into a travel ball season where, their weekends are filled with 2, 3, sometimes 4 travel games per day every weekend. So I certainly think that the load is a key piece to that. And, you also brought up the nutrition standpoint as well. And I see that quite a bit as well. I would say, just clinically speaking, I would say the biggest issue we have is a lack of caloric intake, really. I think that there's a lot of, more general or more specific things that you can get into from a micronutrient standpoint and that sort of thing. But a lot of the times the athletes I see, they're just not pulling in enough calories per day in the first place, let alone enough of a specific nutrient. And, this is an area where I think that, getting dietitian and other providers involved can be very helpful and essential when and where you can. But in general, I would say a lot of athletes tend to feel and do a lot better when they just bump up their caloric intake, for generally speaking.
Yeah, no, I mean, I think you hit it on the dot. I feel like 90% of the kids that come in and see me in the clinic are doing sports year round, and even worse, most of them are doing a single sport year round. So, with club sports and specialization nowadays, the kids feel like, and I'm starting to feel like to a certain extent, though I didn't believe this, that if they're not partaking in the things year round, unless they are the best of the best on the team, they might not have a starting spot on the team. And the real problem is that a lot of this specialization is starting earlier, but by the time they're hitting puberty, which is at the time a lot of these athletes are at increased risk, they're having a lot of bony development happening during that period. There's a lot of changes from a puberty standpoint. They're pretty much have games and club sports year round, whether it's school, multiple practices during the week, sometimes 2-a-days, and then like 3 or 4 games on the weekend. And how do you expect anybody to be able to keep up with that? And it's the same stresses over and over and over again. So if you're doing, multiple sports, you get a break from the specificity of the movements. But unfortunately, it seems to be the way of things even more and more these days. But yeah, I think that, that's definitely one of the biggest factors. And then, I had a case come in. When we talk about nutrition and getting a nutritionist involved, I feel like this is the one area where most of the PTs that I casually talk to are thinking about, but they're not often doing, rather because they don't know a nutritionist to send people to, or, they just haven't done it before. But if somebody has a stress injury, they certainly are having some type of nutritional deficit. Generally speaking, it is because of that lack of bony recovery, and not having enough caloric intake, as you mentioned, is going to be a direct part of that. So I think every single person that comes in, needs to be screened. I recently had a 16-year-old basketball player who came in, who I was like, well, tell me a little bit about what you eat. And she's like, oh, I eat a ton of food. And then I kind of get mom brought into the conversation. She's like, oh, she doesn't eat much at all. And so I think there's also some that they have a lack of realization of like what is a lot of food to support my needs. And if you're having 2 practices a day and ton of games, when do you even have time to eat?
Yeah, no, that's a great point. And I mean, just understanding too that, a lot of these injuries that we're seeing just from an age and demographic standpoint, I typically see them in teenagers or like college kids. And I don't know about you, Josh, but when I was in college, I felt like I could eat anything and everything and not gain weight. It was like, the magic years, so to speak. And that was me who wasn't playing any organized sport at the time. If I'm playing a sport where I'm probably burning, I would assume a minimum of 400 calories an hour for a 2-hour practice, 800 calories, a day just from practice seems reasonable, just general off the cuff math from my standpoint. It's like I have to increase my intake by at least that much in order to just kind of break even. So, I think when you have these conversations with kids and you say, look, like, just from a general mathematics standpoint, we might be coming close to like 3,000 calories a day just to break even. A lot of people get shocked because they're only pulling in 2,000, or that's what's recommended. So that's what they're doing. And, I think we have to come to that understanding that, the athletic population is very different from the general population as far as nutritional needs and caloric needs and so on that way. And the other thing you started to touch on, kind of a case there in a basketball athlete. I think that, the more people you can get involved in these cases, the better off it is. Especially for, you and I, we're both male PTs, and I don't know about you, but I think the majority of the stress reaction type injuries I see occur in females. And it can be very, very awkward to talk about some of the different things that we need to discuss with female athletes. But if it's just me, 26-year-old male provider and that 15-year-old girl sitting in front of me, it can make for some awkward conversations. So I like to actually get parents involved and get other people involved in this process because, at the end of the day, we have to have conversations about things like, female athlete triad and that sort of thing. And if we're not willing to have those conversations, we're ultimately doing our client a disservice at the end of the day. But we have to do so in a way that's professional and respectable to everyone involved, I would say.
Yeah, no, I couldn't agree more with you, Daniel. I think that is definitely one of the biggest things is they need multiple touch points. They need to hear these same concerns from multiple people. So I definitely want to get the parents involved. And oftentimes what I'll do is, I'll do the evaluation with the athlete. I'll ask them some questions. I'll make sure that they understand that I'm talking to them and I want them to be heard. And then I'll give them some exercises to do. And while they're doing the exercises, I'll kind of bring, mom or dad over. Usually I feel like it's mom, and that works better with some of the young female athletes, and just be like, hey, so, here's some of the thoughts that I have. Here's some things that I think that you should, talk to your daughter about. Because, bringing up menstrual cycles and if they have regular periods or if it's irregular, it doesn't have to be that they just miss and don't have them at all. It could just be that they are irregular, but that can definitely be something that needs to be addressed. I'd love for them to go see a sports medicine physician, particularly one who actually has experience working in this area. Otherwise, sometimes these things can more or less get brushed under the rug, especially if they're getting better regardless from a pain standpoint. And like we talked about earlier, even if I'm telling them, and I'm not a nutritionist, right? So I'm not giving specific nutrition advice. We might consult on nutrition about some strategies that I think can work well, but I want them to understand that they should also go talk to a nutritionist because say that you have the 16-year-old female who needs to eat 3,000 calories a day, and they don't have the appetite to do so. They definitely need some strategies to figure out how to hit those nutritional markers. Otherwise, they might just burn themselves out of the sport completely.
Yeah, no, I think that's a great point. And again, the importance of collaboration is absolutely essential and cannot be overlooked in this population in particular. And, especially on the female athlete side of things, I feel like at the end of the day, I'm not always the best person to have those conversations with them, simply because I can't really relate to those kind of struggles myself. But I think that if you're not willing to make the referral to address those things, again, you're really doing the athlete a huge disservice. And it's one of those things that it's better to have the conversation the first time and get it squared away early, because as you mentioned earlier, I've seen a lot of these cases reoccur over and over and over again because things are missed and, brushed under the rug or just kind of overlooked entirely and not addressed. And it's like, the better we do the first time we see one of these at getting everyone involved and managing it correctly, the less likely we are, hopefully, to see this again clinically.
Yeah, most definitely. And again, the worst thing that can happen is they have these repetitive injuries. They think that sports are not for them. They self-select out of sports. Not only that, but between the ages of, like, I think for women 11 and 12, puberty, to 21, 25 is where you build most of your bone density. This is the time period in which we need to make sure that our female athletes are doing weight training and are properly eating and have basically the best athletic abilities that they can to build healthy long-term bone support. If they're having these issues the entirety of their high school athlete livelihood into their early college, they're potentially going to have issues later on, bone density issues, potentially osteopenia or osteoporosis. So it can affect more than just even self-selecting out of sports.
Yeah, no, and I think that the sooner we address this, just from a overall healthcare standpoint, as you mentioned, the less likely we are to run into issues way down the line. And, I know a lot of times when we're working with athletes, it's so easy to get tunnel visioned on the performance and the immediate and the right now. But, ultimately, we cannot forget where that person, I should say, is going to be in 20, 30, 40 years' time as well. So as far as these bony injuries go, you mentioned you see quite a few, referred to you under a variety of different diagnoses. What kind of typical examination considerations are you seeing when you get someone sent to you for PT for, bony stress reaction or stress fracture or something along those lines? Or, do you ever, examine someone who just comes into you via direct access? I'm not sure I'm assuming you have that in Oregon. If someone comes in direct access, how are they presenting to you? And is there anything that, you usually see pop up that's like, hey, look, we're referring this out right now because I think it's possibly bony involvement?
Yeah. Great question. So I'll touch on this from two standpoints. One, the person who's been sent to me by a physician and a referral. And secondarily, maybe that person who hasn't seen a referral or a physician. And I have a case study that we can kind of talk about a little bit later of somebody who came into me directly who hadn't seen a physician that I missed a stress fracture on, and they actually ended up having a complete fracture. Kind of the worst case scenario, but once you hear the situation, you'll be like, wow, I don't know that I would have thought any more of that either. So it just shows us how we need to be aware of some of these factors and how they're involved. But okay, so most of the people that I see, I would say, do not see a physician first before coming to me. My clinic is somewhat specialized, just seeing that we see a lot of active people and we're pretty searchable online. So people will just come in off the street pretty regularly. That being said, most of the young athletes that I see that have potential stress fractures do come in after seeing a physician. So they're probably already been put in a boot if it's in a lower extremity fracture, and or they're not having any pain so that they don't feel that they need to be booted for a period of time. But if I'm going to do an examination in the area that we think might have a bony stress fracture or some type of bony injury, the one thing that I'm definitely going to look at is just trying to find some focal tenderness to a bony region, especially on that bony area. If it's more in the muscular tissue or more diffuse, maybe I'm a little bit less concerned about it. But if you think that they might have a bony fracture, a stress fracture, and you're going to kind of push directly on that bony area, and that is exactly where the pain is, you're thinking that maybe you want to be a little bit more concerned about it. From what we're taught in physical therapy standpoint, I remember learning all the different type, like the fulcrum test and all of those different things. And I think the fulcrum test in specific looks at femoral stress fractures. I've done some of those in the past, and I don't really feel like I've ever gotten positive results on them. I did have a kid back when I was at Cincinnati Children's Hospital with a femoral stress fracture, like a neck stress fracture. But they weren't positive to this test. But the test that I'm often seeing positive with people is if you have somebody with a stress fracture and you have them jump on one leg repeatedly, they will almost always report pain specifically in that area. Now, I mean, this isn't super specific to stress fractures, right? But people who do have stress fractures usually will have the pain. And when I was at Cincinnati Children's Hospital, one of my mentors told me that an even more specific test would be to do like a zigzag single leg hop. So I'll often do that one as well. But from a pure clinical standpoint, those are at least a couple things that I'm going to pay attention to, right? Can we kind of rule out that it doesn't really seem to be in the muscle tissue, or maybe even provoked by like open chain movements that stress the muscular area more? And do they have some focal tenderness? And if it's a lower extremity, does that hop test reproduce the pain? And if you pair that with some of the subjectives, right? So I think just to throw a statistic in here, when I was looking over a paper, it said up to 70% of elite athletes competing in weight class sports are dieting and have some type of disordered eating pattern to basically get down to that weight. And so, if you ask them about some of those different factors and they have all of these things in conjunction with some of this, or they're a distance runner, I would immediately want to, if they haven't already seen a doctor, send them in to see one.
Yeah, no, I think that was a great rundown, especially on the point of this importance of the subjective. I feel like that's a point that we keep coming back to on podcast episodes over and over and over again, but it's continuing to hold true. At the point I'm at, which, all full disclosure, I did not do a residency or anything like that, but I'm spending much less time on test items and special tests and that sort of thing, and a lot more time really getting a good subjective and asking some of those more detailed questions, because I think the better you can paint that picture of what has led up to the athlete coming to see you at this point, the better you're going to be from a diagnostic standpoint. I think you brought up great points with the fulcrum test and the one leg hop. I also haven't really seen a whole lot from the fulcrum test. And I believe there was one that I distinctly or vaguely remember, I should say, about auscultation, where you would kind of put a stethoscope on part of the bone and tap to make sure it transmitted sound. And I've tried that multiple times without any real success that way, even in athletes who have confirmed injury on MRI. So it's one of those things where tests are good, but they're not perfect. And I think that even test item clusters, like, I've referred people because they met certain Ottawa foot and ankle criteria and different things that way. And they go and they get their imaging and it's nothing. And then there's times where they match those things and I send them and what do you know, we found something. So it's one of those things that they're only so good. They're never 100% accurate. And I think that's something we as clinicians, we need to understand. I know a lot of PTs that I've talked with in the past, they get upset when they send someone and it's like, well, now they just had to pay a copay, or they had to, pay $40 to get the x-ray or whatever. And, there wasn't really any point to getting it because it didn't show anything. And it's like, well, you do realize if it did show something and you caught it, it's better that you caught it then and there than letting it go unchecked. So, we can do everything we can to kind of guide ourselves clinically, but none of us are ever going to be shooting 100% with this.
Yeah, for sure. And to address a couple of those points there, one, in the case that I'll talk about later, not that I even remotely suspected a stress fracture, but if I would have had this person get or just an x-ray, they certainly would have shown to have bilateral stress fractures, one of which did completely fracture and they needed surgery. So, I mean, you inconvenience somebody a little bit, but that's the potential outcome. I mean, totally worth it. But to touch on your second point there, I talk to my students about this all the time, because I remember learning in PT school or hearing from early mentors how really good PTs spend a lot of their time looking at objective tests, because the objective test is going to tell you without confounding variables, what you need to address. And then when I was at Cincinnati Children's Hospital, I had a mentor tell me that he's like, look, I actually think it's the reverse. The more that I learn, the more experience that I get, the more that I realize that spending time asking people the right questions about everything they've been doing, all these little factors, help make my objective very controlled and minute, right? Like more efficient. And then I only collect the things that I feel like I need now, so I can spend more time working on the details. So I talk to students about all the time about, in the beginning, I feel like you only ask what the book tells you to ask. But by the end, you know all this stuff, and your subjective is actually longer, and you don't have to have quite as long of an objective.
Yeah, exactly. And, there are still certain special tests. Like if someone comes in and I note a positive Lockman, like, yeah, I'm referring them pretty quick based on one special test, but I'm probably doing that Lockman because, non-contact, knee injury, I don't know, playing like a field sport, hurt a pop, swelled up, couldn't walk, like all that other subjective stuff as well. But I completely agree. And we brought up imaging a few times, and it's interesting too, because, as we're discussing this, a lot of states are now allowing PTs to order their own imaging. I think Arizona might have just passed some legislation about this, and I haven't looked into it in detail, but there's, states that are allowing PTs to say, hey, order an x-ray or order an MRI for some of these things. So when it comes to this conversation of stress fracture, where does imaging come into play? And is there anything other than imaging that we should possibly be looking at, like bone density or DEXA or that sort of thing?
Yeah, those are great questions. And actually, that's interesting. I didn't know that there are more and more states starting to allow imaging. I can almost guarantee you that Oregon will not be one of those states anytime soon. We cannot even do dry needling here because of the fact that basically the acupuncture and medical board was like, no, that's what we do, and we don't want to lose our business, which I'm okay with. I don't want to necessarily do dry needling. I just think it's funny what type of restrictions we put on people to get all the services they need. But yeah, as far as imaging goes, the x-ray is for most things, because of how cheap it is, it's going to be that first line of defense. And so, if somebody you suspect is really high risk, or if a physician expects they're high risk, right? Like some of these subjective things, like you think that they do a lot of repetitive sports, they probably have some disordered eating. Maybe you even find that maybe they have some menstrual dysfunction. I'm probably just sending somebody in, especially if they have that focal tenderness, like go get an x-ray and make sure. Now, if this is a more acute thing, the big thing to note about an x-ray is that oftentimes it's not going to show up on x-ray for the first couple of weeks. And secondarily, if it's not a very big stress fracture, sometimes it's just going to kind of show up as some periosteal like swelling and inflammation, and they're not going to even see it on an x-ray anyway, even past the 2-week mark. But I think if you were seeing somebody conservatively and maybe they didn't have a ton of these factors, but they had some of that focal tenderness, and you saw them for, you know, 4 to 6 weeks, 6 to 8 weeks, and they weren't getting any better and they still had it, I would probably at least be referring them in for an x-ray. As far as CT goes, CT scans are basically a bunch of little x-rays, and so they can see kind of greater layers of things, and so it's going to be a little bit better, and it can also help rule out other pathologies. I mean, so I did the ortho resident Cincinnati Children's, and so that is the population where you sometimes are seeing some of these congenital disorders come into play, or there's various hip conditions, skiffies, that you want to make sure that there's nothing else at play. So they might use something like a CT just so they can see a little bit more. Now, the gold standard is an MRI. However, most insurance companies are requiring at least I know sometimes that physicians can skip it if there are certain factors that show up, but otherwise they're mostly making people get around 6 weeks of PT before they allow it. And then an MRI should specifically show anything that they have going on. So as far from a diagnostic perspective, and that's also going to get your soft tissues in there. As far as from a diagnostic perspective, MRI is going to be your gold standard. It's the most sensitive. X-ray is so-so, but it's cheap. And if they have a pretty serious stress fracture, like a high-risk stress fracture that's kind of going pretty deep, that should be able to give us an indication and basically get them non-weight bearing as fast as possible. And then you mentioned DEXA scans, things like that. So for those who don't know, a DEXA scan basically is able to look at bone density. It's kind of like an MRI, if you've ever, for people who know what it's like to be in an MRI, except it doesn't take nearly as long. It's like 15 minutes max. And basically you lay down on a bed and a wand goes over your whole body, and it sends a bunch of tiny particles, I think tiny x-rays that just don't have as high of levels of radiation, and it will give the bone density as well as your body fat percentage and things like that. So at the clinic that I work at, I would say the majority of people are coming in for a DEXA in relation to body fat. So maybe they have a goal, they want to lose weight, they want to build muscle, they're going to get an initial DEXA, they'll come back 2 to 3 months later, see if they've made progress. However, for somebody who has some of these continued issues, or maybe we're worried that their bone density has already been affected, getting a DEXA scan can tell us some factors of their total body bone density. So yeah, it's definitely something. I don't know that it needs to be a first line of defense, but if somebody is having continued issues and maybe they're having some blood work done and other things like that, it's probably a good thing to just add in and make sure that we can rule out that you don't have any crazy low bone density, and that's not something that we need to be working on or worried about in the long term. And yeah, we can maybe talk about that a little bit more.
Yeah, no, I think that the DEXA scan is certainly an interesting point of conversation. And it's one of those things that I've kind of started to ask the question of, why are we not considering this more often in this population? Because I believe, correct me if I'm wrong, but I believe the cost of a DEXA scan is actually cheaper than the cost of an MRI.
Way cheaper.
Yeah.
Way cheaper. And you can theoretically do it like outpatient, no referral, if there is a place in town that is offering it.
Right. So with that in mind, significantly lower cost and gives us really good information relating to bone density. It's something that I've been quicker to ask questions about, or educate patients about, like, hey, this might be something we want to have discussions about with a doctor, or just consider looking into, because the detrimental effects that we see when we have someone who's 3 or 4 or 5 bony stress injuries deep and they're still not back to where they want to be, anything and everything I can do to prevent those situations from coming up, I want to be able to do. So I think the DEXA scan makes a good entry point here. I know that there's like different Z-score type things as far as like what's normal, what's not normal. I'll be honest, I don't know those numbers right off the top of my head. But what I do know is that just because you might have a score that's low bone mineral density doesn't necessarily mean that you have to stay there, right? You mentioned before, we talked before a bit about how nutrition can play into this. But obviously, bony loading, right? Wolff's Law, bones are going to adapt to the stresses that we place on them. So I think that adding strength and force and the ability to just load tissue over time safely and progressively becomes an essential part of the overall rehab here. Is if we don't ever load the bone and we just keep that person on the table, 3 sets of 10 straight leg raises and then poof, discharge from PT, then we're really doing them a disservice, because ideally we help them return to a level of function that's greater than it was previous to injury. And if you have some of these objective data like the DEXA score to compare to before and after, that's even more ideal, because you can hopefully maybe show them that, hey, we're able to get you to a higher bone mineral density score 6 months after injury than you were right before you injured, or something like that.
Yeah, for sure. So one thing I'll say is pretty cool about my clinic is, now given that this is marketing, but we give all physical therapy patients their first DEXA for free. And so if you're a physical therapy patient, you can just sign up, get your DEXA done. But so, it's easy for me if I have a youth athlete who comes in, or anybody that I have suspected of some of these issues. I'm like, hey, you get a free DEXA, go sign up and do it. If it comes back great, you never have to do one again. I don't care. If it comes back not so good, then we can talk about that. But yeah, so we don't need to get too much into like Z scores and T scores and stuff like that, but or maybe any clinicians who are listening that are interested and don't know the difference. A T score which is standard to give out. A T score is basically, and that's kind of what you learn being the cutoffs for osteoporosis, penia, and PT school. But it basically just compares your bone density to the average bone density worldwide. But Z scores compare it to people within the same age, sex, and body size. So for a young individual, like pre-menopause, we actually would want to know the Z score, because we basically want to see if there's something going on that we wouldn't expect at that young age. But more importantly, to touch on some of the other stuff you talked about, is especially in these youth athletes, and I believe that the greatest amount of bone density is built between about 11 and 25, somewhere in that range. 11 and 26 are the numbers that I remember in my head. I'm pretty sure that's accurate. And so, yeah, if somebody is on the lower end of normal, for their age, sex, and body size, we can definitely still have an impact on that. And Wolff's Law, just like you talked about, making sure that they're engaging in weight training, making sure that they feel comfortable in weight training, and so that we're basically encouraging this as a lifelong activity. Certainly in the past, just since we're talking a little bit more about female athletes, there has been negative connotations with weight training in women and them getting bulky and things like that, which I think is pretty well debunked, that the only way that you're going to get really bulky is if you really, really try to get bulky. But making sure that they're confident, so that maybe when they get to college and they're kind of on their own in the gym, they don't feel nervous going in there, because that's probably the biggest barrier that I hear from college to post-college aged women, is that they're like, well, I don't want to go in the gym and have people kind of look at me for doing things funny. So yeah, there's still, like, if they're having bony stress injuries in this time period of their life, there's still a lot of adaptation that can be done. And we know that you can still build bone density later in life too. It's just, or at least help maintain it as much as possible. But the biggest impact we can have way into adulthood is during this adolescent athlete timeframe.
Yeah, no, I think that's a great point. And, I realize that there's a lot of factors and a lot of things to consider in this population and with this injury in particular. And you mentioned or referenced a case study that you had multiple times there. Kind of want to dive into that a little bit just to kind of apply this a little bit more and put it all into like a practical application point, so to speak. So you were mentioning that essentially in this case study, your athlete ended up having bilateral stress injuries that way.
Yep. So here's the case study, and this is and where I've totally been given permission to talk about this case study as much as I want in anything. This person is actually a coworker of mine. She actually doesn't fit the demographic perfectly. 25 years old, CrossFit athlete. But a lot of these CrossFit athletes are doing 2 workouts per day sometimes if they have the time for it. Especially the higher level people, and there's definitely an emphasis on pushing your body as hard as you can and keeping up with other people. So basically, and I think the PTs who are listening to this can appreciate how easy it is to miss something like this, but doing a lot of squatting movements, was having some anterior knee pain and came into me for those symptoms. And during the examination, it pretty much just presented like your typical patellofemoral patellofemoral pain syndrome, something that we see multiple times a day. It's probably one of the easiest things to have an impact on. I've been trying to think back, like, did I do, and it was both sides, but it was one side was more painful than the other. And, I talked to her about nutrition and things like that. And that was definitely a hard area for her to address. And I think that there were some aesthetics, like, trying to maintain and get to certain aesthetics, the societal pressures, especially for women to be really thin, right, were having a factor in there. And that's for a lot of our adolescent athletes too that are feeling that way. But I'm trying to remember back that if I, did I palpate and were her patellas really tender? So I guess to preface, this is bilateral patellar stress fractures. So anyway, I saw this individual for a session. It really presented exactly like I would expect patellofemoral pain syndrome to present. And I know we all know patellofemoral pain syndrome doesn't mean anything. It's just a generic way to say that you have pain in the front of the knees. But most PTs would agree that these usually respond pretty positively to therapeutic exercise. And so I gave her some things to work on. Because she was my coworker, I really only saw her for one session. And then we kind of just talked about things outside of it. And she went on and she was like, yeah, things maybe got a little bit better, but they're still painful. And we had talked about doing another session. And then she was walking down the stairs. Her leg gave out and patella just snapped in half. I mean, non-traumatic, walking down the stairs, completely snapped in half, transverse fracture of the patella, which means that you have to have, open reduction, internal fixation. So she got open reduction, internal fixation. And at this point, I'm like, okay, there's definitely more stuff going on. And luckily, we're close enough that I felt comfortable talking to her. And she's an adult, about things like menstrual cycles and nutrition and stuff like that. And, come to find out that, she's always had a little bit more of just a hard time with food and struggling with trying to get more in shape. And she had lost a lot of weight in the past. And so she was always kind of fighting to get to that next level. So nutrition was kind of a sticky point. And on top of it, the problem is that now you're also having to, a lot of these adolescent females and adult young females are on birth control. And so oftentimes when I ask them about that, they'll be like, well, I'm on birth control. But she was reporting irregular periods. So sometimes it's okay if they're irregularly regular, meaning that I don't get a period every month, but I get one every 2 months. But she was like, honestly, it's kind of all over the place. And so, more and more after I'm talking to her after the fact and asking more details, it's like, okay, like there were already some of these things going on that I just didn't think to ask about. So we talked about those things. I sent her in back to, this is like, the patellar stress fractures are super rare, and bilateral patellar stress fractures are there are only 2 case studies that I could find in the entire literature, and they were both college-aged female athletes, a gymnast and a basketball player. So it doesn't really occur. So again, another reason why it didn't even pop into my mind.
Right.
And actually, I've been meaning to write a case study with the surgeon who did the procedure. But okay, the case gets more complicated. So we're treating her for the surgical side. The surgeon they did an MRI not on the side that didn't break. It also had a stress fracture. And they just decided that they would put it in a bracing protocol. And so she was double braced for like 6 weeks, walking around basically kind of like a penguin. And 8 to 12 weeks go by, probably 8 to 10 weeks, and she's going in for her follow-up. And I talked to her about, I was like, hey, ask him about the left side, because she had still had some occasional pain. And I was like, they said they weren't going to re-image it unless she was having issues, but I was like, make sure they re-image it. And they did imaging again, and the stress fractures on the left side were completely non-healing. So no progress at all over about 10 weeks of time. And so she ended up having to, basically 3 months after having a surgery on the right-hand side, she had to have her patella fixated on the left side. And so, something that could have realistically, if caught, even though it was, again, something that I missed, hard to probably diagnose. This was a whole year of rehab for her, and something that affected her not only physically, but psychologically. Her identity as an athlete. I mean, if you think about, you've got essentially 2 broken legs. Basically, I got her on an upper body bench program, and I was like, all right, let's just get your bench as strong as possible. Like, let's find things that you can focus on in the meantime. And then it becomes, I think, a long-term thing. Like, people that have disordered eating, that's something that oftentimes they're gonna struggle with, deal with, need outside intervention in the long term as well. It's really, really hard to work on some of those factors. But before I let you talk and ask more questions, so interestingly, I was like, okay, you need to get a DEXA done. So she got a DEXA done, and her Z-score was 0.1. 0 is normal. So 0.1 is like, you're just normal. And then about 6 months afterwards, we ran a repeat DEXA, making sure, she told me that her nutrition has improved. She had been working on a lot of that stuff, not training as hard, and her bone density was up to a 0.6. So, I mean, that's a pretty good improvement in a 6 month, 7 month period of time. And what does that mean clinically? How significant is that? Yeah, I don't really know, but it does show you that even in a 6 to 8 month period of time, improving nutrition and taking down some of that repetitive stress. And this is whole body score, so that we're not even talking just her lower extremities, because we'd have to run special tests at our clinic, which we don't regularly do, to look specifically at like just the tibias. We can look at the lower extremity, but we can't just do just the tibias. So, but yeah, feel free, any questions or thoughts that you have about that case study. I mean, it's honestly pretty crazy. I did not expect to see anything like that, but it basically shows you, like, and again, I don't necessarily hold anything against myself. I think looking back, I'm like, what would I have had to seen to send this person in for an X-ray right now? And I don't know exactly what that would have been. So
yeah, and it's interesting too, because as you mentioned, the patella stress fracture is so rare. It's not something that we really see that often. So it is one of those things where it's like it's so easy to miss, as you just mentioned, and it's easy to miss, but it's also something that I think once we become more aware of it, right? Like, now that we're doing this podcast, now that we're doing all these different things, it's like, okay, now that we're, kind of refreshing the memory, so to speak, and coming to an understanding that's beyond, basic entry level clinician, now we really can't miss it, right? Or like, in this case now, it's like, okay, Josh has had this whole case happen. Next time you get a patellofemoral one, I guarantee you it's going to be like, wow, my exam flow and everything I do is a little bit different because I don't want to miss this again, right? So it becomes one of those
For sure.
things where, it's okay to miss because, like I said before, no one is perfect. No one ever shoots 100%, but it's not okay to miss and stay there. So I think it's one of those things where, when things like this happen, we kind of use our put our clinical hat back on, try and learn from it like you did, and then figure out what we need to do better next time. So I think that
Yeah.
you kind of writing this up and presenting it is an absolutely essential piece to that puzzle, for
Yeah.
lack of a better way to put it. So I think that's huge. The other thing I guess I'll add to it as well is, the importance of, as you mentioned, like the long-term outcome. Like, it is possible to get to that higher ground in 6 to 8 months, like we talked about. So, I think this makes a good case for that collaborative rehab model that we talked about earlier, getting the nutrition, dietitian side of things involved, getting that addressed, getting good PT involved, and so on. That way, you can certainly make great change, great impact, over a relatively short amount of time. Realistically, 6 to 8 months might sound like a lot, but like we started this podcast with talking about, time goes very, very fast. The other
Yes, it
piece that I
does.
think is interesting, you mentioned about how one was a non-healing stress fracture, and I see that quite often, and they're not always
Yeah.
operated on. Sometimes it's just, hey, this did not heal, and we're just gonna go on with that. So what's your take
Yeah.
on the non-healing stress fracture side of things?
It's so interesting. First, I'll say just to kind of wrap up our previous point. Yeah, I mean, this is why I think the subjective and as you get more advanced as a clinician is so important. If you go to a PT and they're not asking you about your training history, what's changed in your training history, if you have somebody come in that's a fairly high level CrossFitter and they're kind of like low body weight anyway, they look very, you should be asking these questions. That should be immediately like what is going through your head, what has changed in their training history, what it's like, and if they're throwing red flags from an energy, nutrition deficiency standpoint, that's you should be addressing and asking those questions. Um, but yeah, non-healing stress fracture. So I actually have a second case that I can kind of talk a little bit about for this one. It's actually my 16-year-old basketball girl. So basically, 16-year-old basketball girl plays club, high level, plays during school too, and she's trying to make the varsity team. I think she's going to be a sophomore, but so she came to me and with shin pain, and basically was put in a boot. Doctor told her that she had stress fractures. She took a period of time off. She went back and played. Pain came back immediately. I went back and the physician cleared them. They're like, yeah, they don't look like they've healed at all, but like you're good to play. And she came in to see me. She went back out and started playing, and she had so much pain that she basically couldn't play at all. I was like, "Can you perform with this pain?" And she was like, "Nope." And I was like, "Well, then what's the point of playing? If you can't perform, you can't show your best. It's not going to help you make the team anyway. Why even go out there and play?" But I was like, "Hey, why don't you go get a second?" And this first surgeon who she had seen said, if it continues to cause you issues, we can just basically do surgery and put rods in your knee or rods in your tibia, and that should help. And that was like their solution. And I was like, okay. And it wasn't a high risk stress fracture area of the tibia. The anterior cortex, and specifically, is the high risk area of the tibia. I think hers was a little bit posterior medial, kind of presenting a little bit more what people often refer to as shin splints or medial tibial stress syndrome. Some bony tenderness, but like kind of right on the inside and behind the tibia, on the medial side of things. And so she went in to see a surgeon for a second opinion, and they ran X-rays and looked at the previous MRI, and they told her, they're like, "Hey, you just have shins," and which, after doing some research, because I started to get a little confused on all this terminology. According to some of the evidence, medial tibial stress syndrome or shin splints it is a bony stress reaction, and it could be a precursor to more serious stress fractures if it basically is left unchecked. Yeah, so honestly, I'm not 100% sure what to think of non-healing stress fractures at this point. I mean, it seems like if they're in low risk area, it's probably never going to turn into a full open fracture. And so they can just continue to participate. But if they're having pain and it's affecting their performance, I mean, what's the point in, continuing to participate? And clearly, we're going to have to take some period of time off of sports and focus on other things in order to get things to heal properly. Yeah, and it seems like long term, even in maybe some lower risk stress fracture areas, if you continue to have pain and it's not healing, some surgeons may be willing to do basically put like a big Nancy nail in there to stabilize things. But honestly, it's a little confusing from a clinician standpoint, because I'm not even 100% sure how to approach these things. And it seems like, I send people to two surgeons or two different sports medicine doctors, and they're not on the same page. So I don't know how any of us, including the athlete and what they're allowed and supposed to be doing, could be on the same page.
Yeah, no, I think that's a great point. And it's something too that, as you mentioned, I find pain and function ends up really being the governor in this sort of case. And it's interesting because typically when I have seen them and they've been able to go about, succeeding with return to performance and so on that way, they're typically in areas like the fibula, where it's not a major weight-bearing bone. But I think you're right. It definitely becomes a case-by-case situation. And I realize we've covered a lot of ground as it relates to stress fractures and bony stress injuries talking today. I would say as like closing things that I think we didn't quite get to, I would say in general from a weight-bearing restricted timeline, I typically see kind of like we started with that 4 to 8 week window period of restricted activity. And I would also say in general, when I do load patients from a rehab standpoint, I do a lot of progressive axial loading. So we do a lot of safety squat bar and Hatfield variations. And I even have a yoke in the clinic that we use, and we literally will make people carry that all over the place. Just as an effort to increase the load through the bony tissue. And I think that, again, loading means different things for different people. But for me, isometrics and heavy axial compression are probably the two that I lean into the most often or most frequently for this sort of thing.
Yeah. I mean, I'm on the same page with you. That's pretty much what my general approach is to kind of starting with things. Usually people do pretty well with axial loading, squats, different movements like that. It's the jumping that will start to get them. And so, we're probably not really starting that until they can tolerate loading pretty well. And then maybe 8 to 10 weeks, at the very earliest, 10 to 12 weeks more realistically, especially if they've been dealing with it for a decent amount of time. There's some talk about, if somebody is dealing with something and they're not participating for say 18 weeks, it's basically going to take about 18 weeks to get them of training time to get them back to where they are. And so I think, the only thing that I'll say is one big focus that I do is if they can't do their sport and they're non-weight bearing or they're some form of weight bearing that they're restricted, how can I give them something that they can still improve on? So for my CrossFit athlete, it was like, she was already a good bencher and she never did bench. It was like, how can we make you an even better bencher, right? It's fun. It keeps their identity as an athlete still there. It allows them to minimize the detraining process, which I think is key. How can we, mimic these specific, energy requirements that they need for their sport as much as possible? But yeah, that's pretty much what I would go with for a low risk. And then, if it's a high risk area of stress fracture, they're probably going to be completely non-weight bearing for some period of time.
No, I think those are great points. And like I mentioned too briefly, I do a lot of isometric exercise with this population as well, just because from a muscular standpoint, soft tissue is a decent shock absorber. So if I can get people to put more load through the soft tissue structures throughout the entire lower extremity, then that tends to be a win for me. They tend to have a good analgesic effect, which I like. And, not to mention, hey, we might be non-weight bearing on one side and 3 sets of 10 side lying hip abduction is allowed, but like, what's that doing for me? Versus if I can turn that into an isometric, a lot of even, in-season non-injured athletes struggle with a 30-second ISO here. So it allows us to actually move the needle forward, in my opinion. And I think it fits this population quite well from everything I've seen. But like I said, we can talk about this all day long. We're really just scratching the surface thus far. For people who want to find out more about you, Josh, and your practice, or maybe reach out with questions that way, where can they find you at online?
Yeah, great question. So my Instagram is probably the easiest way to find me and message me, and the handle is just BTB Rehab. I also have a website, www.beyondbarbelltraining.com. And then the clinic that I work at, if you're local to the Oregon area that accepts all insurances, is Apex Performance Wellness and Rehab. But yeah, a good touch point is just go over to Instagram, type in BTB Rehab, find me, send me a message if you have any questions, and I can always point you in the right direction.
Awesome. We'll link to all of that in the description below. That way, if you didn't quite catch it, you can just click there. Josh, this was awesome, man. I really appreciate your time and all the insights you shared.
Yeah, thanks so much for having me on, Daniel. It's been a pleasure.